So the largest section is anemia, right? Now, we did an anemia long case during the clinical appointments, and I gave you a clinical approach to anemia. And I told you that when you're investigating anemia, it's always important to do a morphological classification of your anemia, right? So that you have to do a morphological classification. And to do the morphological classification, you need information from the red cell indices in the full blood count and also the blood film, right? So these are the things that you need to look for. And I told you that there are three morphological types of anemia. So we have microcytic hypochromic anemia, normocytic normochromic anemia, and macrocytic anemia, right? And this table gives you the causes of each of these three types, right? So microcytic hypochromic, normocytic normochromic, and macrocytic anemia. So this is an easy MCQ. It's just asking you for the causes of microcytic hypochromic anemia, right? So iron deficiency is right. Sideroblastic anemia is a rare bone marrow red cell disorder which can cause microcytic anemia. That is also true. Vitamin B12 deficiency causes macrocytic anemia. Autoimmune hemolytic anemia can cause normocytic or macrocytic anemia. Anemia of chronic disease is typically a normocytic normochromic anemia, but can also cause a microcytic hypochromic anemia. So that is true, right? So this is very basic medicine, very basic hematology. The morphological subtypes of anemia and each of the causes of each type. That is very important. Easily we can give you an MCQ on one of these things, right? So microcytic hypochromic anemia, as you know, iron deficiency, thalassemia, both alpha and beta thalassemia can cause microcytic anemia, anemia of chronic disease, sideroblastic anemia, and these very rare things like lead poisoning and copper or zinc deficiency, right? These all causes microcytic hypochromic anemia. Hi, any questions from that one? There shouldn't be, because it's an easy one. Hi. Right, now I talk about some of these concepts in this slide as we go on. Right, so let's talk about iron deficiency anemia. So in iron deficiency anemia, you get a microcytic hypochromic anemia, and the diagnosis is confirmed with your iron profile. True or false regarding iron deficiency anemia is the most common cause of anemia worldwide. That is absolutely correct. In all age groups, you see this. It is the commonest cause of anemia worldwide. Right. Now, iron deficiency anemia presents like any other anemia, but has certain interesting symptoms and signs. Right. You might have already heard of Pica, mati kali kanawa, pinggang kali kanawa, that sort of thing. Pica is associated with iron deficiency anemia. And also this very rare symptom of dysphagia, right? So iron deficiency anemia causes this esophageal webs, right? In surgery, they would have told you of something called Plummer-Vinson-Mallory-Weiss syndrome, which can cause esophageal webs, and that might cause dysphagia. Right. And also in the examination, you will be seeing signs like this. So you see these typical spoon-shaped nails or koilonychia and angular stomatitis as shown in this picture, right? And you can also get a bit of glossitis as well. Glossitis is actually very severe in B12 deficiency, right? But you can get it a little bit in iron deficiency as well, glossitis and angular stomatitis. Right. And this is a picture of these esophageal webs that you get in Plummer-Vinson-Mallory-Weiss syndrome, which is associated with anemia, iron deficiency anemia. Okay. Now, the next statement here, so as I told you, the diagnosis of iron deficiency anemia is based on iron profile, your iron studies. So the third MCQ, it's a bit of a tricky MCQ, but that's okay. Serum ferritin is a reliable indicator of bone marrow iron stores. So that I will have to take as true, but I'm sure that you know that you have to be very careful when you're interpreting the serum ferritin when in the setting of inflammation. හරියටම මේ MCQ එක හරියටම හිතුවොත් එහෙම the best indicator of bone marrow iron stores is actually the bone marrow iron stain. So you do the bone marrow aspiration and do an iron stain, or it's called a pearl stain. That is the gold standard measurement of bone marrow iron. And I just see it's a reliable indicator. I can take this as correct, right? Because it's a reliable indicator in most situations, because we don't do bone marrow in all the patients with iron deficiency in never. So serum ferritin is a reliable indicator, but the point there you have to remember is ferritin is an acute phase reactant. So whenever there is inflammation, the ferritin goes up, and you have to be very, very careful when you're looking at the ferritin in somebody with an inflammatory disease. If you take the blood picture for iron deficiency anemia, you will see red cells of different sizes and shapes, pencil-shaped cells, target cells, and the microcytic hypochromic cells. But with teardrop cells, you will see. So the technical or hematological term for this is called anisopoikilocytosis. That means red cells of different sizes and shapes. Right. Okay. Now, how do we treat iron deficiency anemia? The treatment of iron deficiency anemia is with iron, obviously, and the thing that we use is oral iron. Most of the time, oral iron is absolutely fine. Now, for oral iron to replenish the iron stores, it takes about 6 months. And the treatment is usually 1 year. So we continue the iron for 6 months beyond that point also. So if they're taking the iron properly, they're replacing their iron adequately, they replenish their iron stores within about 6 months, and then you give another 6 months of treatment to top it up. Actually, one of the first things to go up is the reticulocyte count. So when you give iron, the bone marrow will now start producing red cells, because now it has got the nutrients, it has got the iron, right? So reticulocyte count right? So one of the first things that increases the reticulocyte count. So it is 300 milligrams of elemental iron. That's what most guidelines agree with. There are some I know that say 200, but it's a range, it's not an exact value sometimes, right? Now, oral iron is very good for most situations, but in your long cases, we would have discussed this, right? We use IV iron preferably in people who have renal impairment, CKD, right? That's a very common use of IV iron, CKD. Very, very common, right? And even pregnancy is also a good indication for IV iron, right? And this is an important statement, right? Usually, IV iron doesn't generate a faster hemoglobin response compared to oral iron, except possibly in patients with severe renal failure. This is from evidence research, right? So most of the time, when you give oral iron or IV iron, it has the same hemoglobin response rate, except in patients with severe renal failure. I mean, what's very, very clear is that IV iron causes a faster bone marrow response. So the bone marrow store replenishment is much quicker with IV iron. Right? So these 2 points for Dr. Matakatiyagan might be important for MCQs. Right. Right. So hematological malignancies, why they call the macrocytic anemia, so it depends on what hematological malignancy nipun. So if there's hematological malignancy in the bone marrow, what it's doing is it's occupying that space and pushing out all the immature red cells into the circulation. So as you know, these mature red cells, for example, reticulocytes, they are bigger than mature red cells. That is why they call it macrocytic anemia, right? Because occupying space inside the bone marrow is pushing out all the mature red cells into the circulation.
Sir, even if it's a normal MCV, we have to consider, we can take hematological malignancy as a differential diagnosis?
You can, yes, you can. Yeah. Normal to high, yes.
Okay, thank you.
Okay, so the last statement is iron stores are normalized within 6 weeks of therapy. You need at least about 6 months of therapy to normalize bone marrow iron stores. The response bone marrow iron store replenishment is clearly faster with IV iron. And it's probably why you give it in pregnancy. One of the important reasons is you want the bone marrow iron stores to replenish faster in pregnancy. So that is why. So that is very clear. But most of the time, if you compare oral and IV, the hemoglobin response rate is very similar, except in renal failure. Right? Very, very similar. Hi. Now this table is a very, very important table. I'm sure in your hematology module, make sure that you're sort of clear with this. What is the profile on the iron status in iron deficiency anemia, and compare that with especially anemia of chronic disease. We'll talk about that later in the next MCQ, but this is an important table for you to know. Long case, even for the MCQs, you will need this. Right. Any questions about that? Question number 2.
Sir, what are the indications for this pearl stain and the bone marrow biopsies?
Even very rarely, I have never seen a bone marrow done purely for the purpose of doing a pearl stain, right? But that is a so-called gold standard of iron store assessment, but we never do it. And we go by the ferritin, but the ferritin is not a perfect test because of the inflammation and related changes. It's not the perfect test, but it is a reasonable test, reasonably reliable test.
Okay, sir. Thank you.
Okay. Now, question number 3 is on anemia of chronic disease, right? So, anemia of chronic disease, as you know, is seen in patients with inflammatory disorders, and it is a contributory cause for anemia in patients with rheumatoid arthritis. No question about that. That is true. Now, how do we get anemia of chronic disease? So, when there is inflammation, you get a whole load of cytokines. For example, these fellows, which I'm not going to go into in detail, right? So you get a lot of cytokines. And as you can see in this picture, there are lots of things that happen because of the inflammatory response. Because of the inflammatory response, lots of things happen. An important consequence of this inflammatory response is that when the methana, right, what happens is the release of iron from the reticular endothelial system, that's where the iron is stored, is not good. But the inflammation suppresses the release of iron for hemoglobin formation. And so it suppresses the release of iron. There is iron, there is a lot of iron there, but it is not being released. The inflammation is in a way, the mechanisms of at this stage, I'm going to ask you this. But the inflammation is, remember, suppressing the release of iron for hemoglobin formation. On the other hand, in anemia of chronic disease, the inflammation causes inhibition of erythropoietin release and also inhibition of erythropoiesis per se. Right? So, red cell production also it inhibits the erythropoietin release. Right? Inhibits the erythropoietin release. Can't answer your question when you do thalassemia. Right? So it inhibits the erythropoietin release, and in addition to that, it sort of traps the iron and doesn't release it for hemoglobin formation. Right? So this is what happens in anemia of chronic disease. Right? Okay. Right. So how would you diagnose anemia of chronic disease using investigations? The first thing is it can cause a normocytic normochromic anemia or microcytic hypochromic anemia. If you measure the reticulocyte index, reticulocytosis it's suppressing erythropoiesis. Remember, so the inflammation is suppressing erythropoiesis. So it's actually the bone marrow is suppressed. So as I have taught you before, if the bone marrow production is suppressed, the reticulocyte count will go down. Right? So like a barrel. Now, what happens with the ferritin in anemia of chronic disease? This is where it goes up. 2 reasons for it to go up. One is that because of the inflammation itself, the ferritin can go up. ferritin inflammation, you can have an increase in the ferritin, right? And also, because the bone marrow is now, actually there's a lot of iron in the bone marrow, right? There's a lot of iron flow in the bone marrow. And also in the body, but it is not being incorporated into hemoglobin synthesis. That is the problem. So because of the inflammation, the iron is trapped. It cannot be released or incorporated into hemoglobin, right? So the ferritin is high because of these reasons. And the transferrin saturation is low because there is no, the problem is that there is no iron, it's all trapped. The iron is trapped in the bone marrow, right? And it cannot be incorporated into anything in anemia or chronic disease. That is what happens. So low serum ferritin is may statement because the serum ferritin is high or normal. High normal or high because of the reasons I mentioned. Now, anemia chronic disease is a very difficult thing to treat, right? And obviously it does not respond well to an underlying therapy because remember there is iron, right? But the iron is all trapped in the bone marrow. It is not incorporated into hemoglobin, and it is just trapped inside the bone marrow, right? Because of the inflammation. So iron you're just going to cause iron overload, right? No point. So what the treatment is for anemia of chronic disease is treat the inflammation, right? So treat the inflammation, and that is going to work for the anemia as well. But in severe cases, we can use erythropoietin, right? So it is used in the severe anemia of chronic disease. You can use erythropoietin because, as I show you this picture, the cytokines, they can suppress erythropoietin production, right? And erythropoietin release. So when you give erythropoietin, you can sort of counteract this process there. So in patients with very severe anemia of chronic disease, we sometimes give them erythropoietin, okay? And that will sort of get the erythropoiesis up and going. And with that, if you can control the inflammation, that will be nice. Two complementary mechanisms. Right. Any questions about that?
So do steroids have a place here?
No.
Okay, thank you.
Steroids in place can be obviously you're treating if your inflammatory disease is treated for that, then it indirectly causes improvement in the anemia. But for this per se, you're not going to give steroids. Yeah. If your inflammatory disease requires treatment with steroids, yes, but not specifically for this.
Right. So yeah, that's a fact. Thank you.
Okay, good. Any other questions? Right. So question number 4 is on B12 deficiency. B12 deficiency. Now, this gives you a long list of B12 and folate causes of B12 and folate deficiency, right? Mainly, this is so. If you focus on B12 deficiency, it could be due to dietary deficiency, which is essentially only seen in vegan people, right? Very strict vegetarians only. And also it can be due to malabsorption. Those are the two big causes of vitamin B12 deficiency, malabsorption and dietary deficiency. Malabsorption can be due to pernicious anemia, where there is a autoimmune disorder causing intrinsic factor deficiency. So B12 deficiency is seen in patients with autoantibodies against intrinsic factor. This is what you see in pernicious anemia, right? Intrinsic factor, it can cause in pernicious anemia, you have autoantibodies against intrinsic factor as well as autoantibodies against the parietal cell itself in the stomach. Right? So you have lots of autoantibodies floating around. B12 deficiency, what you get is oval macrocytes. I've shown this picture to you before in the appointments when we were getting ready for the OSCE, right? So these are oval macrocytes. Oval macrocytes that you see. Round macrocytes are commonly seen in things like liver disease and pregnancy. In B12 deficiency, you see these oval macrocytes. Right. Now, when we are doing anemia as a long case, I told you that vitamin B12 deficiency can have other clinical manifestations. For example, it can have neurological involvement. That you can get neurological involvement in B12 deficiency. And two of the important neurological syndromes that you get are dementia and also this subacute combined degeneration of the cord, where they have posterior column degeneration. Posterior column degeneration. Right. Okay. And the treatment is in B12, but remember it has to be IM, oral B12. There are no preparations also. The B12 preparation should be given intramuscular. Right. Oral දෙන්නේ. Okay, right. Any questions about this one? Okay.
Sir, could
So, Sachin, you know about this folate business, right? So, in biochemistry, they taught you about this folate trap hypothesis. So, if there's coexisting folate deficiency, you have to give simultaneous folate. Only if there is folate deficiency that you have to give them folate and then the B12. Tablets, iron, folate, B12, but those are nonsense. They don't work. If there is B12 deficiency, the only way of treating it is giving pure IM B12. None of these tablets have enough B12 to for any sort of clinical effect. Yes. Okay.
So these B12 injections are given with neurological manifestations or
No. They are B12 deficiency, you can give the IM B12, there's no problem. There doesn't have to be a neurological manifestations for that.
And so this, the oral syrups, the B complex,
they don't have enough. They don't have enough of the vitamin for any sort of clinical effect. All
right. Okay.
Yeah. And especially if you have something like pernicious anemia or a malabsorptive problem, which is commonly the case, it's not going to be absorbed anyway. So IM then only. Okay. Round macrocytes in liver disease, pregnancy, alcoholism. Yes. So yes, neurological manifestations are almost completely reversible. Cord disease, not very much, but dementia, dementia on that improve B12 in patients who have B12 deficiency. That is. Okay. Right. Now the next few MCQs on hemolytic anemia. Right. Then make a kalin kira as we do the MCQs. As I taught you this during the appointment. I'm sure for most groups I've done it. Yes, mixed edema can also cause round macrocytes. That's right. So in the appointments I did a long, most of the groups I did a long case on hemolytic anemia. In that I told you that there are certain general features of hemolytic anemia, common features of hemolytic anemia. Some of them are summarized in this slide, but I'm just going to discuss that as we do the MCQ. So in hemolytic anemia, a general feature would be the fact that they have jaundice, and this is an indirect hyperbilirubinemia. And indirect hyperbilirubinemia, not a direct, right? Because remember what happens is because the massive delivery of bilirubin into the liver cannot cope up with the conjugation. It's getting a massive load of bilirubin coming in, and it cannot cope with that conjugation, right? Cope. So then you get accumulation of indirect hyperbilirubinemia. Another common feature of hemolytic anemia is the increased LDH, and this is because of increased cell turnover and release of LDH. Right. Now I told you that some people have the predominant hemolysis in the vessels. right? Now, most of the time, the hemolysis occurs in the liver and the spleen, which is to a certain amount in the bone marrow also, because that is a reticuloendothelial system. But in some people, the hemolysis occurs inside the blood vessels, right? And this is called intravascular hemolysis. Now, in intravascular hemolysis, what happens is they get a release of hemoglobin directly into the circulation and also goes into the kidneys, right? And that can be toxic to the kidneys. Right? So they get hemoglobin urea, renal tubular toxicity because of that. Also, this hemoglobin urea can sort of aggregate and cause hemosiderin granules in the kidney and the urine. You get hemosiderin urea, hemoglobin urea, right? And what happens is this, what the body does is, because this free hemoglobin is extremely toxic. Free hemoglobin is very toxic. So what happens is the body tries to mop it up with the serum haptoglobin, which is a plasma protein. So the free haptoglobin fraction goes down, right? Because it's trying to mop up the free hemoglobin. So the free fraction would go down. So these are some considerations that you get in a patient with an intravascular hemolysis. Right. So a serum haptoglobin මෙතන අපි හන්නේ free fraction එක අඩු වෙනවා. හරි. So when you say serum haptoglobin, always measures the free fraction, right? So it's reduced, because there's a lot of haptoglobin which is binding the free hemoglobin. A chronic intravascular hemolysis can result in iron deficiency. Yes, that is true, because in principle you use hemoglobin, but this time in your urine. Urine, so that can cause iron deficiency, right? Finally, if you do another important test that is not in this MCQ is reticulocytosis. So in hemolytic anemia, what your body is trying to do is trying to compensate for this hemolysis by producing more and more immature red cells, pushing them out into the circulation. The immature red cell, it is pushing them out into the circulation. So this can cause an increase in the reticulocyte count and index, right? So increase causes the reticulocytosis and also causes a reverse erythroid to myeloid ratio in the bone marrow. So more erythroid cells, erythroid hyperplasia. Usually myeloid cells vary, but then when you have hemolytic anemia, you have more erythroid series cells in the bone marrow. Right. So these are the general features of a hemolytic anemia. Any questions from this one? 5. Okay. Right. Now this again we have done in the clinical appointments, the classification of hemolytic anemia. So there's hereditary and acquired. Then hereditary membrane defects, there are red cell enzyme defects and hemoglobinopathies, right? And the acquired, you have mainly the big group is the immune hemolytic anemias, right? And then you have a series of other non-immune hemolytic anemias, right? Like fragmentation syndromes, which we'll talk about in an MCQ. So this is a rough classification, right? So this first MCQ is just asking you a few details about these types of hemolytic anemia, right? Now, hereditary spherocytosis, as you know, is a red cell membrane defect. And the problem is in that anchoring protein in the red cell membrane, the ankyrin band 3 protein. Yes. So, Dania, since sometimes intravascular hemolysis they cause microcytic hypochromic anemia, right? So that is possible, yes. Because it's iron deficiency, because they're losing hemoglobin in their urine, right? But yeah, if you use your brains, you can diagnose them, right? So hemolytic anemia, hereditary spherocytosis, ankyrin band 3 protein problem, and that causes hemolytic anemia, and it is autosomal dominant most of the time. That is right. A common presentation for this is pigment gallstones, right? Take the hereditary spherocytosis, pigment gallstones. මම මෙතන තමයි MCQ ටිකකුත් දීලා තියෙනවා ඔයගොල්ලන්ට මේකේ. General MCQ ට අහන ටිකක්. හරිද? One, I think that we'll have to ask is this aplastic crisis එකක් එන්න පුළුවන්. I think head spherocytosis, parvovirus B19 infection, right? And you see these spherocytes, you can see in the blood film there, and there's increased osmotic fragility of these spherocytes. There are some newer techniques now, investigation techniques that people use to diagnose this also, but they will right. So hereditary spherocytosis. G6PD deficiency, the classical feature, it is triggered by certain things that increase the oxidative stress. Oxidative stress can cause hemolysis. මෙතන මම ලොකු ලයිස්තුවක් දීලා තියෙනවා, especially antimalarials. Primaquine and tafenoquine කියලා very related drugs, and also things like sulfonamide antibiotics, salicylic acid, aspirin, high doses, right? These can trigger off hemolysis. And if you look at the blood film, are typical white cells, blister cells, and there are Heinz bodies. Heinz bodies. Right. So primaquine triggers hemolysis in patients with G6PD deficiency is true. And white cells, blister cells, and you can actually measure the G6PD enzyme levels for confirmation as well. Right. Right. So we come to red cell fragmentation syndromes, or mechanical heart valve. These are all red cell fragmentation syndromes, right? And these are non-immune mediated. Examples of red cell fragmentation syndromes are HUS, TTP, mechanical heart valve induced anemias, because the golden gas valvular cadena, right? Yes, autoimmune hemolytic anemia, usually the Coombs test is positive. That is also true. We'll talk about autoimmune hemolytic anemias in a bit more detail in the next few MCQs. Right. Okay. Heinz bodies, yes, you need a special stain. But yes, you can do a special stain to confirm. Okay, right. Any questions? So spherocytes mostly it is a normal MCV, yes. Good. Right. The next thing is about thalassemia. Now, I'm not going to go into detail in this because maybe what are pediatrics, but I'm sure you by now you should be familiar with this sort of table classification. And pediatrics, they would have gone much more in depth into this, which I'm not going to do. So you have alpha thalassemias and beta thalassemias. Yes, so I'm not going to go into detail into these, but I'll just do the MCQ and I'll answer. So beta thalassemia causes microcytic hypochromic anemia, and there is another parameter that we assess in the full blood count, which is the red cell distribution width. Now in iron deficiency anemia, because there are lots of different sized and shaped red cells, the red cell distribution width is increased. But in thalassemia, we describe the red cell distribution width to be normal because the cells look abnormal, but they have the same size and shape. Target cells. But in iron deficiency, you get target cells, long cells, character cells, cells, all of these things. And isopoikilocytosis is the technical term, as I told you. Right, that is right. ARNW in thalassemia. So cause of microcytic hypochromic anemia is true. So remember in Sri Lanka, you can get these various other types of hemoglobin disease associated with thalassemia. One of the famous ones is HBE disease, and the other one is sickle cell. You can have HBS with thalassemia, a mix of that. It's very unusual to see pure sickle cell anemia in Sri Lanka. You see a coexisting variant with thalassemia, or HBE disease and thalassemia. These are some of the things that you see. Now, in the blood film, what you are seeing in beta thalassemia is a microcytic hypochromic anemia with a lot of target cells. We'll also see nucleated red cells. Nucleated red cells are also a feature of thalassemia. Rehani, yes, so aplastic crisis can occur with parvovirus in the congenital hemolytic anemia, but especially things like hereditary spherocytosis we see quite often. Right. Right. Now, for beta thalassemia, we have beta thalassemia major, thalassemia intermedia, and thalassemia minor. Right. Now, remember, of these three, thalassemia intermedia can sometimes present for the very first time in adults. Very first time in adults. They come with anemia and you need blood transfusions. The mechanisms of beta thalassemia are very complicated, and there are multiple genotypes that are associated. Multiple genotypes. And this hemoglobin electrophoresis is also variable in beta thalassemia intermedia. It is a difficult entity to diagnose, and obviously you need a hematology review for that, and sometimes we talk to people in Ragama like Sacit Mestananda, Amja Premvardhana to help with the diagnosis, because that's a very complicated bit of thalassemia intermedia. Right. Now, thalassemia major you are very familiar in pediatrics. Thalassemia minor you see in adults also. Sometimes you diagnose this. Right. So thalassemia major, the main thing is a very high hemoglobin F. Very high hemoglobin F. That is the key thing in thalassemia major. Right. In thalassemia minor as well, you can get a bit of a hemoglobin F, but hemoglobin A2 will be high. Right. That is the important thing in thalassemia minor. So beta thalassemia මොකක්ද කියලා කියලා නෑ. Hemoglobin A2 is elevated is true. Right? That is true. But a පොඩ්ඩක් variable වෙන major වල එච්චරම A2 එකක් අපි දකින්නේ ඒක වෙන්නේ hemoglobin F තමයි පිරෙන්න තියෙන්නේ. There is a whole load of hemoglobin F, right? And a little bit of hemoglobin A, right? In thalassemia minor, you start seeing yes, there is a bit of hemoglobin F, a reduction of hemoglobin A, and a slightly higher as well hemoglobin A2. You know, pediatrics already. Finally, now thalassemia, we do treat with hematopoietic stem cell transplantation, bone marrow transplant. Right. Okay. So don't expect a lot of MCQs on beta thalassemia in the medicine paper, but of course in pediatrics they will learn a lot of this. So make sure that you study that. Any questions? Sickle cell crisis එච්චරම අපි දකින්නේ නැහැ. So there are various types of sickle cell crises. The common thing is painful crisis. Painful crisis. And the treatment is with opioid analgesics. You need to give them opioid analgesics. They can also get this lung crisis where there are oxygen drops and you get sickling in the lungs. Again, we do, that's associated with pain as well, opioid analgesics, and they sometimes need an exchange transfusion. Right. It is a very difficult thing that and I was completely horrified with that because no point we never see sickle cell anemia, and there's no point in asking that. Right. MCHC in thalassemia is variable. Like අඩු ගොඩකට අඩු පැත්තට තමයි තියෙන්නේ. හරි. ඒ සමහර ಜಾති වල normal වෙන්න පුළුවන්. Right. Right. Now this is how microangiopathic hemolytic anemia looks like. අපි මේක දැකලා තියෙනවා blood film එකක් in when we did the OSCE classes. Right. Right. Let's talk about autoimmune hemolytic anemia next, and that's an important MCQ ආනෙකක්. So autoimmune hemolytic anemia is classically described as warm and cold. Warm and cold autoimmune hemolytic anemia. The words warm and cold are assigned because of the simple fact that these are the temperatures where the antibody best reacts with the red cell. This is where that's a temperature that best reacts. React right? With the red cell. So you have warm autoimmune hemolytic anemia where the temperature is around 37 Celsius, and in cold decay, it's about 4 Celsius. Right. Now, if you look at the tests for these autoimmune hemolytic anemias, all will have a Coombs positive. Coombs have a positive, they will get warm, cold, decay. But you can also do something called a Coombs profile, where you can test the type of antibody. What antibody jati is. So when you look at the Coombs profile, you will find that in warm type, it is IgG, it is IgG. And in cold, it is IgM, and you also get this complement fragment called C3b on the red cell, right? So you get IgM and C3b positive, right? In cold autoimmune hemolytic anemia, right? So acrocyanosis is seen in cold autoimmune hemolytic anemia, right? Acrocyanosis is peripheries nikan cyanose vela because the peripheries are the coolest in your body. The red cell lysis, hemolysis occurs with right? In the fingers you get hemolysis, and that causes condition called acrocyanosis. That is cold autoimmune hemolytic anemia because those are the coolest areas of the body. There are several secondary causes for both warm and cold autoimmune hemolytic anemia. Right? And I have even used some of them here. Right? Cold weather, causes. One of the famous causes of cold autoimmune hemolytic anemia is mycoplasma. But there are some other causes which right? Be familiar with these things. Causes of warm autoimmune hemolytic anemia and cold autoimmune hemolytic anemia. Right. And there are certain drugs that cause autoimmune hemolytic anemia. Methyldopa is a recognized cause. Again, cold autoimmune hemolytic anemia. Drug list warm cold දෙක වෙන්න පුළුවන්. හරිද? For methyldopa. එක slide එකේ එකක් තිබ්බා. Right. Warm autoimmune hemolytic anemias are most often near IgM level. Warm IgG ගොඩක් වෙලාවට. So this is false. Right. Now this MCV story, when you do an autoimmune hemolytic or see an autoimmune hemolytic anemia, commonly the MCV is very, very high. Right? There are several reasons for this. One of the main reasons is because of the antibodies which are floating around, the red cells start sticking to one another. Red cells stick right? And the machine doesn't know that this is a clump of red cells. Right? So it counts as one big red cell. So MCV very better because the clumping, the technical word is agglutination. So you have very high MCV. Also, because of the increased erythropoiesis in the bone marrow is producing a whole load of red cells and pushing out the immature red cells into the circulation. And these immature red cells are bigger than usual as well. Right? So these are the reasons why your MCV can go up, and we can discuss in the long cases. Right? Treatment is for warm autoimmune hemolytic anemia. Steroid, they respond beautifully to steroids, but not so much the cold. Cold doesn't commonly respond to steroids. Sometimes we use rituximab, works nicely in cold. Warm responds very well to steroids, and then we give a course of steroids and then switch them over to something like mycophenolate or azathioprine. Right. Final thing, in general, blood transfusion is bloody difficult in these patients with autoimmune hemolytic anemias because there are a lot of antibodies floating around. That are reactions, because of that. Right. Any questions about autoimmune hemolytic anemias?
So how does the cold type happen, sir? As in the body temperature doesn't drop down to 4, right?
No. Cold can be the word cold is a laboratory description. But remember that the specific feature of those antibodies are they react with the red cell at a colder temperature. So sometimes when the hemolysis because the reactivity is increased, just the feature of the antibody, property of the antibody. Right? So when they go to colder climates, they start hemolyzing. Right?
All right. Okay.
So when you have a transfusion mismatch hemolysis, it's called alloimmune. Autoimmune alloimmune. Called alloimmune hemolysis. Right. Now, question number. So, Vishwa Goda Velavata, most of your hemolytic anemias are extravascular, but things like PNH, PNH, that is intravascular. All these red cell fragmentation syndromes are intravascular. It causes there, most of them actually are extravascular. For intravascular PNH, some of these fragmentation syndromes, those are intravascular. Right, and in the intravascular investigation findings, hemoglobin in the urine, hemosiderin in the urine, low circulating haptoglobulin levels, you will find all these things. Sometimes it will be presented AKI also, right? Because the tubular toxicity of hemoglobin. Okay, make a nikam meda aplastic anemia causes, right? And I've given you a table of causes there. Just have to go and right? For secondary causes is chloramphenicol gold were famous right? Right. So right. Now let's move on next to hematological malignancies. Right? Hematological malignancies. Now, hematological malignancies, again, most of your questions will be in pediatrics. Adults, things like acute ALL are not even heard of in adults. Right? But of course, CML is an important thing. Right? CML is an important thing. Right? And CML is actually classified under a myeloproliferative disorder as well. Myeloproliferative disorder. And you know that there is a genotypic gene problem, and you get this Philadelphia chromosome, right? 922 translocation. And you see a large amount of myeloid cells in the blood film with mature and immature, they come a mix again. Right. Chronic myeloid leukemia. So, question number 10 now, right? Associated hemolytic anemias, common take a boru kata, CLL wala hemolytic anemia ka kenna puluwa. CLL common naha but cannot. Right. In chronic myeloid leukemia, the underlying genetic defect is you get a Philadelphia chromosome or a 922 chromosomal translocation, which gives rise to a proto-oncogene activation. It's positive, yes, that is true. And actually, if the Philadelphia chromosome is found in a patient with CML, the prognosis is good. It responds nicely to treatment. But if you have a Philadelphia chromosome negative CML, they have a bad prognosis. Right? Philadelphia chromosome negative CML, the prognosis is not very good. Okay. Right. So remember, in chronic myeloid leukemia, you get a myeloproliferative state, lots of white cells. lots of white cells. Right. Chronic myeloid leukemia, massive splenomegaly, that is a cause of massive splenomegaly. Right. මේ හතරෙනි කපා ගන්න එක එච්චර හොඳ දෙයක් මම මේ ස්ටේට්මන්ට් එක ගන්න නෙවෙයි නේද. We'll talk about thrombocytopenia. You can get thrombocytopenia, but common than at the everything. No point in talking about that. Right. How you treat chronic myeloid leukemia is with imatinib. Right? It's a tyrosine kinase inhibitor. And actually, it reduces this. So when the Philadelphia chromosome is formed, you get transcript, BCR-ABL transcript. When those genes come together, you get this common BCR-ABL transcript. When you use imatinib, the levels of the transcript go down, right? And that is it responds beautifully to imatinib. Right? This BCR-ABL transcript level, and you can monitor it with that as well, right? Of course, if you're unfortunate to get a cancer, this is a cancer that you might like to have. If you're unfortunate to get a cancer, this is good because you can actually treat this completely. Chronic myeloid leukemia can be treated completely with imatinib, and you can actually see the levels of this BCR-ABL transcript, which is formed from this Philadelphia chromosome, going down, right, when you treat it. So imatinib is a very good drug. It's a tyrosine kinase which is used in the treatment. Very effective and very, very effective. Philadelphia chromosome negative නම් prognosis එක එච්චර හොඳ නැහැ. එතකොට ඉතින් කචල් වැඩි. Right? And this is a very slow malignancy also. බොහොම කලාතුරකින් තමයි ඔක වාත වෙන්නේ. Right? Very, very rare. This can suddenly transform into an acute leukemia, which is a bit of a dangerous situation, but that is rare. Right. Any questions about CML? Okay. Now, question number 11 is on lymphoma. Now, traditionally, දැන් අතර මේ classification එක ටිකක් outdated වේගන යනවා because there's a lot of improvement in immunological diagnosis and sort of genetic signatures of lymphomas now. But traditionally, when you describe Hodgkin's lymphoma and non-Hodgkin's lymphoma, it's purely based on histopathology. Right? In Hodgkin's lymphoma, you get this very typical cell, which is called the Reed-Sternberg cell. So that is the diagnosis, right? The presence of this Reed-Sternberg cell in Hodgkin's lymphoma, right? Whereas in non-Hodgkin's lymphoma, you do not get this Reed-Sternberg cell. You can insert. This is the simple diagnosis, right? Histopathologically, we classify karane. Now here I have given you a rough comparison of Hodgkin's lymphoma versus non-Hodgkin's lymphoma. Make a classification that outdated pagan error, but you might still get an MCQ on this. So as I told you, the classical feature of Hodgkin's would be the presence of this special cell, which is the Reed-Sternberg cell, right? And I've given you various etiologies for Hodgkin's and non-Hodgkin's lymphoma, right? Now, classically, in Hodgkin's lymphoma, they have lymphadenopathy starting in one group, one lymph node group. So the lymphadenopathy starts in one lymph node group. Right? So they have neck involvement, right? Lymph nodes in the neck as the first presentation, right? Lymph nodes. And then it spreads contiguously. One to another contiguous spread. Right? So you get contiguous spread. Patients with Hodgkin's lymphoma B symptoms night sweats, in the long case, night sweats, weight loss, fever, nocturnal pyrexia, and sometimes these sort of generalized itching, right? Unusually, lymph node these are all related to Hodgkin's lymphoma. So it is a very ordered පිළිවෙලට යන cancer එකක්. Starts in one node group and then goes to the other and then goes to the next one. ගොඩක් වෙලාවට use this supradiaphragmatic node involvement තමයි ගොඩක් වෙලාවට එන්නේ. Right. But non-Hodgkin's lymphoma doesn't follow a pattern. It can spread anywhere. Right? And there is no nice pattern එකක් විදියට එන්නේ නැහැ. It can go extranodally, it can cause leukemic phase එකක් එන්න පුළුවන්. So these are the problems that you see. And they are very weird, unusual manifestations. So ALL වල Philadelphia chromosome එකක් එන්න පුළුවන්. ඒක pediatrics වලදී ඒක ඇත්තටම අනිත් පැත්ත. If you get a Philadelphia chromosome in ALL, it is poor prognosis. Right? But ALL is a pediatric leukemia. I don't even talk about it here. Right? So Hodgkin's lymphoma, non-contiguous, it is a contiguous lymphadenopathy. Hodgkin's lymphoma, extranodal involvement is very, very rare. It usually sticks to the lymph nodes. It is a non-Hodgkin's lymphoma, that is, it goes extranodally, it spreads into the bloodstream, causing a leukemic phase, right? And right. Now the next one is tricky. Hodgkin's lymphoma is known to present with paraneoplastic syndrome. But it's actually a non-Hodgkin's that has the most amount of paraneoplastic manifestation. Right? Hodgkin's lymphoma, you can get paraneoplastic syndrome. For example, nephrotic tenderness, right? You can get this neurological syndrome sometimes. So known to present is true. Right? Known to present is true. Elevated LDH is diagnostic in බොරු කතාවක්. Right? So LDH is not a diagnostic test for lymphoma. සමහර ළමයි උක විල විභාගෙට කියන lymphoma diagnose කරන LDH කරනවා කියලා. Remember, LDH is not a diagnostic test for anything. It just shows you that there is increased cell turnover. Cancer LDH very well. It is not diagnostic of a lymphoma. Right? The diagnostic test for a lymphoma has to be histopathology. Right? That is the gold standard. You have to do a histopathology, and the pathologist will tell you the diagnosis. Right? You can't diagnose it with blood tests. Right? It is a histopathological diagnosis. Right? Any questions on the table එක පොඩ්ඩක් බලන්න Hodgkin's non-Hodgkin's අතර වෙනස compare in this table. Any questions on question number 11?
Sir, does non-Hodgkin's lymphoma ඒකේ B symptoms නැද්ද?
නැත්තේ නෑ අඩුයි අර තරම් නෑ.
Right.
So about 99% of Hodgkin's lymphoma you get B symptoms, but non-Hodgkin's එකේ you don't really get. Samarth is asking very difficult questions over Samani number. Usually I would say generally Hodgkin's lymphoma has a better prognosis, but of course that is very difficult to say because remember now I sort of told you in the start, we go a lot by the immune markers, we go a lot by the genotypes. So the treatment is mostly decided on those things and the prognosis is decided on that rather than the fact that it's Hodgkin, non-Hodgkin care. Right? There are also other ways of determining prognosis now, but generally, yes, Hodgkin's, so you can say the prognosis is better generally.
Also, sir, what's the Epstein fever in Hodgkin's lymphoma?
Tell Epstein fever, that's supposed to be a mythical manifestation. So, as starting the Kapuna Dimbri, they don't know. I have never seen it, and people don't agree that it does exist here.
Right. Okay. Thank you.
Yes. Good. Okay. Question number 12 is on multiple myeloma. Right? And for most groups, I also discuss this. So multiple myeloma is a malignancy of plasma cells. Right? Most often in the bone marrow. And what they do is they produce a single type of antibody. A ජාතියක antibody එකක් විතරයි හැදෙන්නේ. And in that antibody also, now if you remember your immunology, which you don't, I'm sure, in antibody there is a light chain and a heavy chain. So most of these myelomas, they produce only one component of that process, one type of antibody, one chain. Most of it light chain එක තමයි ගොඩක් වෙලාවට හැදෙන්නේ. Light chain. Right? So that is what you get. It's a monoclonal antibody production. right? And the problem is that it can cause end organ damage. That is the problem. So it can cause lytic lesions, not spherotic lesions, lytic lesions. It can cause hypercalcemia. Right? Hypercalcemia, lytic lesions. It can also cause several problems in the kidneys. Right? It can cause AKI, CKD, and something called renal amyloidosis. It's an abnormal protein deposition in the kidney. So that's an important problem. So renal amyloidosis can also cause renal AKI, CKD. There are several mechanisms behind that which I don't think are important now at this stage. Right. So these are the problems of this disorder. Now, in order to diagnose this, bone marrow is the final thing that you do, yes. But before that, you have to demonstrate, if possible, that there is a monoclonal gammopathy, right? Monoclonal gammopathy. And the best way to do this is by electrophoresis or immunofixation. Immunofixation is better than electrophoresis, right? And it actually can give you much better results. And then you show that, right? And then you do the bone marrow. Remember that not all myelomas give rise to these monoclonal proteins. You can't detect them in some myelomas. Those are called non-secretory myelomas. So, හැමෝගෙම monoclonal gammopathy එකක් ඉන්නේ නැහැ, right? Some of them are non-secretory myelomas, right? Okay. So polyclonal gammopathy feature in බොරු කතාවක්. Serum beta-2 globulin is a prognostic factor in මතක තියාගන්න. That is true. Now, this is an interesting business in myeloma. සාමාන්‍යයෙන් අපි කියනවා myeloma ALP will be normal. Unless there is a significant fracture, the ALP is normal in myeloma, right? ඒක මතක තියාගන්න. That is an important point. හරි. ඒතර මෙතන මේ ALP එක තියාගන්න මෙතන මේ note එකේ තියාගන්න. ALP is usually normal. It can be elevated if there is a fracture, right? Only if there is a fracture. Right. May go to the cerebellum, and you have, these are the typical lytic lesions. Right. Any questions about this one? CLL, no. CLL is again bone marrow. Yes, CLL in the bone marrow. Yes, sorry, I thought you asked me lymphoma. Yes, but those are not very important for you. Right. Okay, right. Any other questions? Okay. So higher the beta-2 microglobulin, the bad the prognosis, right? Worse the prognosis. Now we end off that discussion on hematological malignancies by just doing something on polycythemia rubra vera. So polycythemia rubra vera is also hematological neoplasm. It is under the category of myeloproliferative disorders. And myeloproliferative disorders. Other disorders in that group include essential thrombocythemia, myelofibrosis, right? The main problem with polycythemia rubra vera is because the blood is so thick and viscous, it presents with arterial as well as venous thrombosis. Right. Okay. If you look at the blood film, you will see a whole load of red cells, packed red cells, right? With teardrop cells, nucleated cells, WBC precursors, ගොඩක් වෙලාවට එන්නේ myelofibrosis වල, not in polycythemia rubra. These are typical findings in myelofibrosis. In myelofibrosis, what happens is there is a proliferation of fibroblasts in the bone marrow, right? And that's sort of what happens is it pushes out the immature cells, white cells, red cells into the circulation. Because the fibroblasts are proliferating, the bone marrow is fibrosing, it's sort of pushing out the immature red cells and white cells into the circulation. Some people call this a leukoerythroblastic blood film because there are nucleated red cells which indicate a red cell problem, and also these immature white cells, leukoerythroblastic. And teardrop cells, in that setting, teardrop cells, which can also be due to iron deficiency, but always setting teardrop cells are in myelofibrosis. Right. Now, how do we diagnose this condition? In polycythemia rubra, where the serum erythropoietin මොකද වෙන්නේ? Because there's proliferation of red cells in the bone marrow, the erythropoietin will be suppressed. Erythropoietin එක අඩු වෙනවා. That will be suppression of erythropoietin, not elevation, it will be suppression of erythropoietin. And then you can have do genetic tests for the JAK2 mutation. And it is positive in a lot of patients. Most patients are positive for the JAK2 mutation. So in the setting of a very high hemoglobin, hematocrit, maybe arterial venous thrombosis, right? A suppressed erythropoietin with a JAK positivity is diagnostic, and we do a bone marrow as well sometimes. Treatment is with venesection most of the time. And you can also give drugs that suppress bone marrow cell proliferation, like hydroxyurea. These are uncommon MCQs. Areas. Right. Any questions from this? Okay, right. So last section then is on bleeding disorders. So true or false regarding the cause of thrombocytopenia. Again, all of these are correct, and obviously thrombocytopenia. Then ITP kind of question, but this is important. When I make a ITP so what a best response MCQ? Best response MCQ number one, you don't give treatment to everybody with ITP. Motor treatment then. So treatment is indicated if they are symptomatic or their platelet counts are less than 30,000. That's when you treat them. And treatment is with steroids. And then you have to know, in emergency presentations in ITP, especially when there's deep bleeding, then we use steroids and IVIG most of the time. Steroids and IVIG. So pulses, methylprednisolone pulse therapy. That is what we use. And also, this is the only indication for platelet transfusion in ITP. I mean, platelet transfusion, then in an ITP patient, there's no point. Because the moment you give platelets, 6 hours later, that's going to be gone. But in an acute setting, when they are bleeding and in an emergency, then you do give platelet transfusions. Right. Anti-D immunoglobulin is very rarely used. Right? Sometimes we use it as an alternative to IVIG that is not available, but available now. At least it's available in maternal hospitals, but we in the it is IVIG. Right. Okay. Right. So even though I put an MCQ on hemophilia A, it's very, very rare that they might ask this from you. Pediatric වල අහන්න පුළුවන් හැබැයි. හරි මෙඩිසින් වල නම් මේක අහන්නෙම නැත්තා. Yeah. Let's go to the best response MCQs. Right. Right. So, question number 1. So, what is the answer here? The key things are that there is vitiligo. Vitiligo, so that should give you an idea of something autoimmune. MCV is high. Right. There are some other things going on also, but we will come back to that. Maybe you can see that there is anemia, there is high MCV, right? But the white cell count is also low, platelet count is also low, right? And the bilirubin is a bit high as well. And the LDH is also a bit high, right? But that's vitiligo indicating some autoimmune process. MCV is high, so now you are thinking of what are the causes of high MCV here. Right. So what is the answer here? Yeah, but
Pernicious anemia.
Pernicious anemia, that's right. So the autoimmune story with the macrocytic anemia is suggestive of pernicious anemia, right? Now, why is there leukopenia and thrombocytopenia? That can occur because remember, when there is very severe vitamin B12 deficiency, it can affect the other cell lines as well. All these cells need vitamin B12 to sort of proliferate and make these cells. So when there is very severe vitamin B12 deficiency, you get pancytopenia. And why is the LDH high? Because what's happening is because of the B12, the bone marrow is producing immature cells and they're breaking down in the bone marrow itself, right? Which can cause a bit of intra-bone marrow hemolysis. And the LDH is high because there are lots of the immature cells are forming and they're breaking down. Because you need B12 for nice cell maturation, cell division. But because that's not happening, it's being broken down in the reticuloendothelial system, LDH, bilirubin. Okay? So that is pernicious anemia is the answer there.
Sir, excuse me, sir. Sir, why can't we take that I has autoimmune hemolytic anemia?
You can't take IHA. So IHA itself wouldn't cause pancytopenia cell action. That's right. So, but B12 deficiency can clearly cause pancytopenia, right?
Okay, sir. Thank you, sir.
Okay. Yeah, sphenomegaly, they have hemolysis. One thing is mainly different hemolysis and pradhana hetu more than extramedullary hematopoiesis. That can happen in thalassemia, but this is a short thing. So that is because of the sort of you can get a little bit of hemolysis in the spleen as well, but mostly in the bone marrow. Release and immature cells spleen. And you can obviously there might be a little bit of extramedullary hemolysis. Folate deficiency can also cause pancytopenia because B12 folate decama you need for cell division. Cell division, cell cycle you need both of these two things. Right. So this is easy. Hematology clinic holiday. MI right? Plethoric. The hemoglobin is very high, right? So are the white cells and the platelets, which can happen in this disorder, right? So what is this and what is the answer? So this is most likely polycythemia rubra vera. In polycythemia rubra vera, you can get thrombocytosis and high white cell counts as well, right? That is also recognized, and the mutation we have already talked about. This is the JAK2 mutation in most of the patients. Right. Okay.
Sir, excuse me.
So.
Sir, polycythemia rubra vera වල අර මේ hot bath එකකට පස්සේ කසන්න හේතුව මොකද්ද?
එහෙම නිශ්චිත හේතුවක් නැහැ. ඒක නිකන් එහෙම තමයි කියලා කියන්නේ.
හරි. Okay.
Right. Right. Now this is a tricky MC, not a tricky one, but let's see what you say for this. So make a patient presenting with some paraparesis, right? Creatinine body, hemoglobin adui. Moment you sort of talk about this, calcium is Right? So there is something nasty going on, either a myeloma or a malignancy, right? With secondary deposits in the vertebral bodies. That is what you think of when you see this story. Right. මොකද්ද මේක ඉස්සෙල්ලාම කරන්නේ? Investigation එක උඩ. So what is the next? What is the appropriate initial investigation? Go.
So urine for creatinine clearance and Bence-Jones proteins.
Okay, now පොඩ්ඩක් හිතන්න. Hematology තොප්පිය පොඩ්ඩක් පැත්තකින් තිබ්බොත් මොකද වෙන්නේ මේක? Just practically think of this scenario. Yes. So, මෙහෙමයි. I won't fault you for going down the line of myeloma diagnosis. හරි. ඉතින් myeloma diagnosis කරා අතරම Bence-Jones protein is a useless thing. You have to do this. Right? Serum protein electrophoresis, quantify the immunoglobulin, අරවා ඒව කරන්න. But in this situation, the first thing that you do is actually press for urgent MRI of the spine. ඒ වෙලාවෙම කරන්න. Radiologist එක කරන්න වෙලාවේ ඒ වෙලාවෙම කරන්න. This is a neurosurgical emergency. Acute cord compression is a neurosurgical emergency. So actually the answer here, even though it's a malignancy or myeloma, and you should investigate for it, but the first thing to do is MRI. පොඩක් tricky ඔය වගේ සමහරලාට ඔය best response එක ටිකක් tricky ඒවා තියෙනවා. Okay. හරි මේකත් pediatric ප්‍රශ්නයක්. මේකට උත්තරේ මොකද්ද? ඉස්සෙල්ලා මටත් මේ pediatric කියලා දෙන්නේ නෑ. මොකද්ද මේකේ උත්තරේ? So this is a coagulation problem, right? And the factor 8 is slightly low. APTT is high. This indicates an intrinsic pathway deficiency, but there is a lot of gum bleeding. When you have gum bleeding, that indicates mucosal bleeding. That means more platelet. So what is this? Yes, von Willebrand disease. That is where you get platelet dysfunction, and also you get this slight reduction in factor 8 because it's the von Willebrand factor that stabilizes that complex. Okay. Right? So this is a typical presentation where platelet functional problem. You get the coagulation event. Right. Yes. Right. What is the answer here? So නිකන් abdominal pain, nausea, පොඩ්ඩේ නිකන් abdominal distension වගේ කතන්දරයක් තියෙනවා. IBS කතන්දරයක් තියෙනවා. There is a anemia with high bilirubin and reticulocytes. That moment you see that, you think it's probably a bit of hemolysis going on. So මොකක්ද උත්තරේ? But whom's negative? Whom's negative? So the answer here is hereditary spherocytosis. So there is a hemolytic anemia going on, or a nausea, abdominal distension, or gallstones. Right? And I told you that gallstones are a common presentation that you see in hereditary spherocytosis.
So in that question, the previous question, sir, how did you exclude porphyria?
Porphyria. This is not the presentation of porphyria. They come mostly with abdominal pain, yes, but neuropsychiatric manifestations again. And you don't get this sort of picture there.
Right. Okay.
Right. Okay, this one, unfortunately, when you make a පාඩම් කරගන්න ඕන එකක්. So this is a patient who has G6PD. G6PD වගේ අහනවා නම් මොකක් හරි කතන්දරයක් උගේ කියන මොනවද බේතක් ගත්තම හරි මොකක් හරි dollstones ඉන්නේ නැහැ සාමාන්‍යයෙන් ඒකට. But that's a very intermittent thing. Most of the time they don't have any hemolysis. Occasionally they have hemolysis when they have some sort of oxidative stress. Right. Question number 6, warfarin. So this is overcoagulation. They are bleeding. right? What you do here is very straightforward. Stop the warfarin, give IV vitamin K and prothrombin complex concentrate. That is the answer. There is no other answer here. Right? If you don't have prothrombin complex concentrate, you can give FFP instead. Right? Okay. Right. Question number 7. Bleeding gums, thrombocytopenia, giant platelets. What is the diagnosis? Platelets chutta liquid. What is the answer?
ITPs.
Mother? Sorry.
ITPs.
ITP, yes, ITP. Right. FFP is an inferior product compared to prothrombin complex concentrate. Right? Prothrombin complex concentrate is concentrated coagulation factors for the extrinsic pathway warfarin inverted specifically. Right? So there is no doubt that you stop the warfarin. Stop warfarin, give the IV vitamin K, PCC. PCC is right? FFP is an inferior product. Then prothrombin complex concentrate නැත්තම් විතරයි. හරි. So ඒක දෙන්නේ නැහැ. Right. Okay. Right. Question 8. Sorry. මේ මොකද්ද මේ? So we have discussed all these concepts. දැන් මේවා අමාරු දේවල් නෙවෙයි, බොහොම ලේසි. So very high white count. Kadara white count platelets චුට්ටක් වැඩි. And you see a range of white cells. ඒවා blasts උත් තියෙනවා, neutrophils උත් තියෙනවා, splenomegaly තියෙනවා. So there is no doubt that this is CML and answer is this. So most of the patients with CML will have this 922 translocation. Most of them, right? And the Philadelphia chromosome. And the gene transcript that is formed is called the BCR ABL transcript. Right. Okay. The last one is this. Make උත්තරේ මොකක්ද? So diarrhea කතන්දරයක්, confusion, right? Low platelets and there is histiocytes. And there are red cell fragments, right? It's a bit of renal impairment as well. What is the best answer from this? Few responses, you know them? Yeah, so this is TTP, right? TTP. Right? So TTP is the answer here. Now these red cell fragmentation syndrome, so HUS, TTP, they behave in the same manner. DIC can also be like it. Main difference is in DIC, the coagulation profile will be grossly off, completely deranged. Right? TTP, where the coagulation profile is normal. Because the DIC, where the whole point there is that they use up all their coagulation factors. So they're using up, consuming their coagulation factors. So that PTINR, APTT, thrombin time, everything will be grossly abnormal. TTP, these will be normal. Right.
So in the previous question, CML, shouldn't the platelet count be reduced?
No. So what happens actually when they proliferate, myeloproliferate venacota, they can have initially a thrombocytosis, and then when progressive bone marrow failure venacota, they will have thrombocytopenia. Right? But as the disease progresses, they can get thrombocytopenia. But most of the time, it is slightly high because all remember platelets are also formed from myeloid cells. Right? ඒකයි.
Yes, sir. Okay.
Yeah.
And what's the place of this neutrophil alkaline phosphate?
ඒක තමයි වැඩි ප්‍රයෝජනයට ගන්න because there are lots of other ways of diagnosing this now. No? So you have the BCI, you can do the 920 translocation, even තමයි ගොඩක් වෙලාවට diagnose කරන්නේ.
Right. Okay. Sure.
Sir, in question 5.
Sir, wouldn't
Jawad Khan.
thank you. Sir, wouldn't TTP usually present with focal neurological signs, sir?
Question 5 වල TTP එකක් තිබ්බේ. මෙතන 9 you mean. Focal නෙවෙයි ඒක generalized වෙන්නේ. ඒක seizures and him. Focal level එන්න පුළුවන් සමහරට thrombosis ඒ පොඩි strokes අනම්මනම් එන්න පුළුවන් but එහෙම එකක් නෑ generalized. ඒකේ seizures තමයි ගොඩක් වෙලාවට එන්නේ.
Okay.
Sir, in question 5, the MCVs towards the high normal level, is that normal in hereditary spherocytosis?
එහෙම විශේෂයක් නෑ normocytic නේ